Great. Thank you so much, Jason. So thank you everybody for joining us today. With so many moving Medicaid pieces, we appreciate the opportunity to talk with everyone about really three topics for today. First up is Medicaid unwinding. And then we'll discuss Medicaid reprocurement, which has obviously been on the table for more than a year now, but happily moving towards conclusion there. And then last, the state of Medicaid expansion in Georgia. So next slide. One more. So Medicaid unwinding. As we had shared, with the end of the COVID public health emergency, Medicaid continuous enrollment has come to a conclusion. So, primarily due to that, there were many more Medicaid beneficiaries who retained coverage through COVID. Jason, can you guys hear me?
Yeah, you're kind of in and out, Kelly. Kelly, can you hear me?
Is that any better?
Yes.
There we go.
Okay. Because the presentation was just spinning on my end. So, with the end of the public health emergency, all states, including Georgia, are now in the position of having to re-verify eligibility for Medicaid. So that process officially started with the end of the public health emergency in May. States have been given 12 months to complete the renewal process for all Medicaid eligible persons. And it was projected that millions of people will lose coverage, and we're starting to see some of that, particularly here in Georgia. So Georgia initiated their process in June of this year, and to date, they have disenrolled more than 300,000 enrollees from the program, which is more than 10% of total enrollment here in Georgia. So their original estimates was that nationwide, Medicaid would lose 12 to 20% of the overall enrollment, and 4 months in, that number has already clipped 12%. Next slide. So this is just a snapshot. Kaiser Foundation is pulling data from all of the states as they go through this process, and it's really mapping the 4 categories that the state is reporting in Georgia. So this is the latest data as of September 2023. So the real 4 categories is that renewed on an ex parte basis, which we'll talk about a little bit in a later slide. That's an auto enrollment option. Renewed via renewal form, you guys can see that is the smallest blue box there that has been processed via the standard process. Terminated for procedural reasons. That is the really alarming orange box that you see that really captures most of the enrollments. And then the gray boxes are the renewals that are still in process the state is working on. Next slide. So the status overall of renewal processing of the disenrollments, only 14% have been due to actual ineligible redeterminations. Some of those are, that you make too much of the federal poverty level now, and some of those beneficiaries will now qualify for other coverage, whether it's Georgia Pathways to Coverage, the Medicaid expansion we'll talk about, or potentially moving into one of the exchange plans or other commercial insurance. But the vast majority have been terminated for procedural reasons, likely lack of member feedback, which is obviously significantly concerning. Of what the state has reviewed, 35% of those have been termed for those procedural reasons, 6% termed for actual ineligibility. For the 33% that have had their coverage renewed, 25% renewed ex parte, percent have actually had an application processed, approved their eligibility, 26% are still pending. Next slide. So talking about the ex parte renewals, this is a huge concern from CMS, that they have instructed most states to stop processing renewals this way. Ex parte is a renewal that the state uses existing, that it has payroll, tax source, state wage data to determine whether people are still eligible for Medicaid or CHIP. What CMS has found as of late August is that due to a programming error, many states, 30 plus, have a programming error that they're doing those renewals on a family level and not an individual level, which is leading to children coming off of the rolls that are likely still eligible. So children have different thresholds for maintaining their CHIP coverage, and when it is renewed at the family or looked at the family level, the children are often losing access to coverage because the adults no longer qualify. So Health and Human Services agency ASPA has projected that 74% of the children who've been disenrolled through ex parte renewals actually remain eligible. And these kind of administrative issues are a key reason why. So what the state has asked, or what CMS has asked all the states to do, is to pause procedural disenrollments for those individuals impacted, and reinstate coverage for all affected individuals until they can rerun the analysis at an individual level versus a family level. CMS is also working with the states to mitigate the impact of that and to fix their state systems. Next slide. And so based on this, we really anticipate that the remaining renewals are going to slow down as states work to fix both the ex parte issue and then the other concern that CMS has. So nationwide, we've talked about what's happening here in Georgia. Nationwide, 71% of the disenrollment as of October 23rd have been for procedural reasons. And what does that mean? It means receive a renewal notice. They didn't update their information per request from the state. Maybe they didn't understand what needed to happen. And in some cases, information has been submitted, but the eligibility caseworker didn't get to that file before the renewal period came up. So they've submitted everything they needed, but the state wasn't able to process it in time. The state ranges that we see are really significant in terms of who is being impacted by this. The highest that we've seen is New Mexico. 97% of their disenrollments have been for this reason, down to 4% in Oregon. Georgia is near the top. 86% of the disenrollments that we've seen here are for that very reason. And based on these, we've heard that many states, including Georgia, are working with CMS on whether we need to pause the unwinding process altogether, occurring while the outreach is not working, to ensure that patient or beneficiaries have the access to renew their coverage.
Hey, Kelly, one point to add to that. Literally, as of this morning, we checked with our contacts at DCH to find out whether or not they had been issued an official, pause, and they have not. They're still in the process of talking to CMS about their concerns, but as of right now, it's still ongoing. And so, from those of you, we're at 12% Medicaid disenrollment currently, and we're beginning to actually see that in y'all's data as we look at it. From a hospital perspective, there's this tip down in Medicaid payer mix and this tip up in self-pay payer mix that everybody probably needs to look at. But for physician practices that don't generally see a lot of self-pay at all, it's just this lowering of the Medicaid volume out there. And maybe it's only 10% of your Medicaid volume is not such a huge concern right now. But if they don't adjust the program and it continues down this path where three-quarters of them are coming off the rolls just for procedural reasons and not for actual ineligibility determinations, that's pretty catastrophic fail at that point for providers. And so, we all ought to be considering our lobbying efforts around, agreeing with CMS that some kind of program slowdown, shutdown, pause, whatever should be part of our thinking now. Kelly?
Yep. Next slide. So Mike, do you want to take this one about
Sure.
what our recommendation for providers would be?
Yeah. So if you think about it, like, and we have these discussions with you guys all the time where it's a struggle. Like, what do you do about this? The major issue is redetermination process starts. The member is not responsive to the forums or the outreach, any of that kind of stuff. And so people start dropping off the rolls, again, mainly for lack of response. And so what do we do about it? And so in theory, you're sort of thinking it through. There's really kind of four types of reviewees: people who didn't respond, and for procedural reasons, whether or not it's right or not, due to that programming issue, they're being disenrolled for that. Second category, they did respond and they're legitimately determined to be ineligible. Okay, all right, that's an area that we might be able to deal with. Then the third category, they were reviewed, determined to be eligible through an actual review or ex parte. And then there's the, probably 3/4 of them that haven't been reviewed in the first place. So our potential response, and we'll talk a little bit more about some tools that are available, or Kelly will in a second, is if they've been disenrolled for procedural reasons, well, we got to educate on what the appeal process is, because they have 90 days to apply and attempt to get back on the rolls. We need to provide assistance, if we have resources to do so, to walk through the appeal, or at least walk them back over to defects to help for them to help do it. And then secondly, if they're legitimately ineligible, if it's due to income, then we educate on regarding the health exchange and other resources available that might be able to provide coverage for them. And somebody who is just over the edge of eligibility for Medicaid is going to be in a very highly subsidized level for the health exchange. And so maybe that's an option for them. And I know some of you guys have relationships with local brokers that you route that population to, and to try to assist with people getting coverage there. Then for our hospitals, there is the indigent care, the dish reporting that we do. Being thorough about that process, whether or not it's an automated or paperwork process, and making sure that we're maximizing the indigent care identification methods that we're walking through. We need to the degree people are coming off the rolls, um, most likely they're going to qualify under your indigent policy. And again, this doesn't help any of the independent providers, physicians on the call, but from a hospital perspective, you can log those, and in theory, that is going to provide some additional funding, albeit a long way after the fact, but at least it's something. And then the last category, the yet to be reviewed, which is the majority of them, posting the notifications in the intake areas, mailing out potentially. I get that feels like overkill, but there's a lot sort of hanging in the process for our typical hospital. If 20% of the Medicaid population moves to self-pay, that's a 7-figure hit. And so there's just a lot kind of hanging in the balance to do something to try to mitigate the impact of it. Kelly?
Next slide. So how we can help beneficiaries, some of the tools that have been made available, because to add on to what Mike said, with all of the procedural disenrollments that are happening now, a Medicaid beneficiary may not know that they've been disenrolled until they're trying to seek care. You may be the first person that is providing that information to them, particularly if they have not received any of the communications from DCH to respond to. And so educating your intake staff, if that situation occurs. So we'll post this, but there are links here to what DCH has provided to their partners in the communities. There are resources available at a Medicaid Unwinding Toolkit, staycoveredgeorgia.gov, which can help beneficiaries walk through. There's a flyer that educates your Medicaid beneficiaries on the process that's ongoing now. reminding them to update their contact information in Gateway. From what we have heard, this is not a simple process. It can be very cumbersome. So whatever resources or tools can be made available, because that is the smoothest way to ensure that they are in contact with DCH to provide the information to ensure that their coverage is not disrupted. And again, if members are truly losing eligibility, as Mike said, they can qualify for other health benefit programs, whether that's the new Medicaid Georgia Pathways to Coverage or the health insurance marketplace. So providing tools and resources around those options for beneficiaries that have lost coverage can be impactful. So for, next slide, for the beneficiaries who have been terminated for a procedural disenrollment, meaning that information wasn't provided, there are 5 steps that they have to follow to appeal that Medicaid decision, and they have 90 days to follow that. So timing obviously is very critical there. So we've included this as a resource as well for beneficiaries who believe that they still should have coverage, but were just terminated for really paperwork reasons.
So before we sort of hard left into the next topic, and at the risk of it being kind of rolling tumbleweeds out there when I ask this, does anybody else sort of have any way that they feel like they've been able to educate effectively educate the population, and you feel like you really are mitigating the impacts of all this? I knew it. I knew I shouldn't ask that. Well, nonetheless, I think we should be all ears, and I think as people come up with innovative stuff, we need to get the word out and sort of educate each other as folks come up with different ways of looking at all this. Okay, next topic.
Okay, moving on to Medicaid reprocurement, which has now moved into the fast lane. So next slide. So, this is just a quick reminder of how we got here. Georgia has had Medicaid managed care now for 17 delightful years. And our last reprocurement was in 2015, and we at that time moved to 4 CMOs. We are back down to 3 now with Centene's purchase of WellCare. So what are we looking at in this procurement cycle now that the RFP has been officially released? Next slide. So this is just a real quick encapsulation of the most recent numbers from DCH about Medicaid enrollment and the average cost. So one of the big things from this is that for the first time, they've talked about it for years, but it looks like DCH is finally making the move to transition the traditional Medicaid population, the age blind and disabled, and other low-income Medicaid into Medicaid managed care. So we are contemplating that switch happening not immediately, but over the course of the coming contract cycle. So next slide. So some of the key dates that we are tracking towards. RFP was finally released by DCH on September 22nd, 2023. The responses are due back from all bidders on December 1st, 2023. DCH has stated their intent to award the new contracts in May or June of next year. And then the new contracts will take effect on July 1st, 2025. The new contracts will run for 1 fiscal year with 6 one-year optional renewals in this next cycle. So we are potentially looking at these contracts taking us through Medicaid managed care until 2031. Next slide. So what have we learned from the RFP about DCH's intentions? So much like the last cycle, their intent is to award up to 4 contracts. So we think this is definitely the way DCH is leaning based on the acquisition and the merger of Centene and WellCare, that they are leaning back towards for contracts. In this cycle, they are also right now putting the foster care population back up to bid. As you guys likely know, AmeriGroup has been the foster care provider for Medicaid for many years. Believe that there is a shift coming and that that contract is going to be awarded to another care management organization in the coming cycle. So as we touched on before, the changes, one of the biggest changes is now carving in age, blind, and disabled, non-dual and non-home and community-based services populations into managed care. So still looking for clarification from DCH, but it doesn't look like the entire population will be moving, but some version of the 2.7 million eligible beneficiaries. And but those are expected to transition in over later years. So there will be population coverage from traditional Medicaid, Medicaid managed care. Next slide. So just a quick recap of their program priorities that they have outlined. And maternal mortality and morbidity, that is a huge one. Medicaid managed care has addressed that over the last several years with Georgia Planning for Healthy Families. So we're likely to see more programs dedicated to and resources dedicated to improving outcomes in this category. As with all Medicaid providers, behavioral health is a huge focus of this contract cycle to ensure access to care. So likely to see a lot of movement from the and programs around that for the coming cycle. Next slide. The Georgia families, this is a continuation of the mental and behavioral health focus. So significant reporting between the state, the Medicaid managed care, and then a promotion of value-based program models for behavioral health providers. And then the additional category, and this is really reflective of not just the population who's in now, but moving in the older Medicaid population or chronic disease management programs. We will see much more of those for the populations with the transition of traditional Medicaid in managed care. Mike, anything to add to those?
No, that's got it.
Okay, next slide. So as you guys know, the field is incredibly packed with who wants in for this. We've got our three incumbents, definitely rebidding, AmeriGroup, CareSource, Peach State, and then the prospects, Aetna, AmeriHealth, Humana, Kaiser, Molina, Centara, and United Healthcare. And I will turn it over to Mike to sort of talk about where things stand with these 10.
All right, so next slide. All right, so y'all are aware, we probably have had this discussion with y'all individually, if not, in a previous presentation, where the theory was that we kind of dumped our entire client base into a messenger model mechanism that, IPA, PHO mechanism that we were cleverly calling SHPPN, SHP Provider Network. And yeah, we spent lots of money figuring out the name of that. But the idea was that if we could use the biggest footprint possible, given the fact that all of the prospects were sort of at a standing start and had to deal with all of y'all at the same time, that our likely best leveraged answer would have been to talk to them as the biggest group possible. Therefore, we initiated discussions with everybody at that level, and it's kind of a mixed bag in the incumbents. It was pretty successful on the prospects. So to walk through them, the incumbents, AmeriGroup, conversation wasn't terribly fruitful, and they have determined that they are pursuing individual outreach of you guys. Again, I'll talk more in just a second. I think the question you got to ask yourself is, what are you getting in exchange for a generic LOI that supports their bid. And at the end of the day, obviously, the provider has to make their own decision. But the point we would consistently be making was, how are they enticing you to do that? The idea that time is running out, therefore you need to do it in order to be included in their bid isn't terribly, it isn't a great argument, because you already have a contract with those guys. And so your fallback is to get exactly what you're getting now. So that wasn't terribly persuasive from our perspective, but nonetheless, Care's Horse and Peach State's a little bit different. I think that those two have sort of indicated that they understand the value of dealing with the group as a whole. And we've now, it was a lot of discussion at front and then kind of some rolling tumbleweeds there for a bit. And now both of them have come back to re-engage. And so we're having active discussions with both of those now. Now, in terms of the prospects, you see Aetna, AmeriHealth, Caritas, Humana, Kaiser are essentially done now. Molina and United are in language review, and we've made significant progress with the two of them. We're sort of past, you probably have already seen messenger rates on those, all that kind of good stuff. And then very late to the game with Centara, which is it's a health plan that's sort of born out of a health system in North Carolina, and it just feels like they're way too late to the game. They've had some discussion. I know they've had some outreach with you guys, but it seems like a lift, a pretty heavy lift for them to put together something and have it ready to be included in a bid by early December. And so we really haven't, not really spending just a ton of time with them right now. Go to that next slide. So, so there's this, with the bid coming out, all right, if you sort of feel it the way we feel it, there was a whole bunch of activity where everybody was sort of tapping on y'all's door, and then it kind of quieted out for a while. But when the bid came out, boom, it was the door knocking has reinitiated and maybe at a different level now. And so there's a huge push to get the letters of intent right now. And so just some things to consider as you sort of think through this, whether or not you're going to come along for the ride in the SHPPN world, or you're doing this thing on your own. Is an LOI is really a vote for a bidder. And to the degree you choose to do an LOI with them, or you participate in SHPPNs, it's a vote telling the state that you're willing to participate in their offering in the future. Therefore, there's probably some requirements that you would have of them to make sure that they're a valid partner in the future. And so it's a reminder that your LOI counts. That's the reason they're beating your door down trying to get it in the first place. Second bullet there is that the time's on the side of the providers. You're going to feel some pressure, and when you go to one of these conferences and get cornered by one of those guys, you're going to feel some pressure, because they're going to have their deadlines, and it's going to feel like that time pressure is your time pressure. But especially for an incumbent, failure to sign an LOI just reverts to using the existing agreement. And so there's really no downside for you to not sort of play the game and sort of try to see what value is in it for you one way or the other. Now, with the prospects, time is equally on your side. And so, signing an LOI sort of votes for their network and their bid. Failure to sign one, if just puts their bid in a slightly less favorable light with the state. And so again, what you do is important, and whether or not you choose to sign one of the generic LOIs or try to put some language in it to protect yourself, it matters, and it's a big deal right now. The third bullet point: the incumbents were required to submit letters of intent to support their network adequacy versus using the existing contract network. The state has made that clear, and so they can't just take the existing network that they have and just say, yes, state, we're all contracted across the state. We don't really need to do anything to prove to you that we have a network. For whatever reason DCH chose to, they've made the ruling that the LOIs, in order to, I guess, to put everybody on a similar footing, the LOIs are the way that they're going to adjudicate network adequacy, which means that the AmeriGroups of the world and the Peach States of the world equally need to get letters of intent with you guys. And so, as I said a minute ago, our general thought would be Yeah, okay, if you want to support a payer that's been supportive of you, et cetera, that's fine. But the general question that we sort of tend to think in terms of is, what is the payer giving the provider to justify the LOI versus a need to just acquiesce to their payer timeline and the requirements that they have. If they got to turn in a bid by 12/1, they're obviously want to be thinking in terms of having their network put together 3 or 4 weeks ahead at that time, which means that now is crunch time for them. And again, not to be harsh about it, but that's their problem, not ours. And that's their problem, not yours. And so we, hope that that's a leverageable point. So that next slide, it's in our mind, what would you then consider? What are the kinds of things that we've been seeking from an SHPPN perspective? If you're going to do this on your own, then what are the kind of things that you would think about doing? Some key considerations outside of rates, which we obviously cannot talk about. Will the payer commit to allow that all the services that you provide can be provided on an in-network basis? I.e., will they commit to not deploying mandatory lab, RAD, or other kind of services redirected away from you and use national, lab vendors or what have you? Will they commit to, if you provide the service, it can be provided on an in-network basis? Second bullet point there, the payer commitment to use fair payer payment policies, pre-authorization rules that are unadjustable over time and that, must be committed to in the agreement. Whether or not we get that or not completely, payer after payer, um, it would be a significant administrative relief should you get that in an LOI to commit them to that for your permanent agreement with them. Third bullet point that we think in terms of it, that's just based on the hospitals, is the elimination of the triage mechanism and the non-emergent mechanism that's been thoroughly abused by the incumbents over time. Not so much CareSource, but the other two have used it much to their financial benefit over time, and to the point that you know we don't even really scream at DCH about it because it's been in place for so long, but it has been incredibly harmful. We have hospitals that are paid a third per emergency room visit versus traditional Medicaid simply for use of that factor. And so, something to consider with an incumbent or prospect would be, where are they willing to eliminate their ability to do that? Then the last one, elimination of the ability to adjust the Medicaid payment mechanisms um, through either shifting over services from the interim outpatient rate to fixed fees, or pray on the physician side, payer specific CPT weightings, other things like that some of the payers tend to do both on the commercial and the Medicaid side. So this list isn't so much to tell you exhaustively this is what to ask for. It's to remind us that there might be value in asking for additional items on a letter of intent that are just beyond the little short form that you're going to get from them. And so, in our mind, we think that's a good thing to think about. Next slide, Kelly.
Yeah, so briefly, switching over to Medicaid expansion, which we're still learning a lot about, as it has gone live here in Georgia in July of this year. So um, Georgia Pathways to Coverage is Georgia's version of Medicaid expansion. This has been an ongoing conversation in the state dating back to the Affordable Care Act in 2013, 2014. Georgia has not expanded eligibility, so we have continued to have really this donut hole of coverage for beneficiaries here, because exchange subsidy eligibility picks up at 100% of the federal poverty level, and current before Pathways to Coverage, Georgia's low income Medicaid was somewhere, I think, in the high teens, 20% of the federal poverty level. So we had this huge gap between what was Medicaid eligible and what is exchange subsidy eligible that just stayed uninsured in that time frame. So this attempts to close that gap. It's eligible for U.S. citizens ages 19 to 64 who have a household income of up to 100% of the federal poverty level, that they do not otherwise qualify for Medicaid. So not replacing traditional low-income Medicaid, but where that leaves off up to 100% of the federal poverty level, are not incarcerated. And then this is the real sticky one, can document that they meet the qualifying activities threshold, what everybody refers to as the work requirement. So current estimates put it that there are about 252,000 Georgia citizens in that donut hole today. The state is indicating that they think 100,000 of those are going to meet these new eligibility requirements. And this is another path to coverage and following Medicaid unwinding. If patients have truly lost eligibility in traditional low income or CHIP coverage, this may provide another option for care for them. Next slide. So the qualifying activities, what does that actually mean? So could be full or part-time employment, could be on-the-job training, job readiness assistance programs, community service, vocational training, Georgia Vocational Rehabilitation Agency, or higher education. 80 hours have to be completed and documented every month. There are some categories like higher education. If you were enrolled at a university, documentation from the school may cover you past more than just the month-to-month verification. But long-term, the real concern and what we'll see play out as more beneficiaries move into this coverage is, the state has not added additional resources to monitor enrollment for this coverage. And what in a lot of cases is month-to-month qualification and having to submit that to DCH. What is the management of that eligibility going to look like? Are we going to see, the state's going to potentially run several months behind in verifying that those 80 hours are met? Are we going to see a lot of continuous disenrollment or retroactive disenrollment of these beneficiaries? Definitely something to monitor as this coverage rolls out. Next slide. And so where are these lives going to go? So unlike traditional low-income Medicaid, which has always been lived with DCH and GAMUS and been processed by the state, the pathways to coverage Medicaid beneficiaries are moving into the CMOs. In terms of your systems and patient management, their cards are different than traditional peach care or CHIP coverage. So these patients are identifiable when they're coming in for care. Any coverage differences, with the exception of non-emergency transport, these Medicaid beneficiaries will get the same coverage as other beneficiaries. So really a seamless transition with the exception of that non-emergency transport. And so what do providers need to do? And know that particularly in the hospitals, that you guys are working with enrollment people now, but for uninsured patients, to educate them on this new coverage, get familiar with the eligibility requirements and how you can sign them up for this coverage. Mike, anything to add?
No, not to that one.
So I think next slide is questions and wrap up.
Great. Again, if you have any questions, please use the raise your hand icon you'll probably see at the top of your screen, or the chat box you'll also see, and we will unmute your line, or you can post your questions in the chat box.
Yeah, I guess the kind of the summary wrap up from our perspective is that there's just a lot of moving parts right now. And some of this, even that we went over today, feels like that it's middle of the game and it's not post game where we kind of know what the next 2 years is going to be like with all this. And so we need to sort of make sure we stay in touch and sort of stay in touch with each other to get the latest, to make sure we have clear information from DCH on how they're guiding these processes, and then react accordingly. But not be passive about it. It's not just let it be done to us. There are ways that we think we can either leverage or mitigate the impacts of all the things that are coming at us right now.
All right. Well, I don't see any questions posted. I think folks must be enjoying the last half of the lunch hour. But again, thanks, Kelly. Thanks, Mike. A lot of great info, timely info covered. And again, everyone, please look for today's presentation and the recording on our website here in the next day or two. And as always, you know, Kelly, Mike, myself, if you have any questions, please follow up and we'll be sure to respond promptly. And with that, we'll give you the rest of the lunch hour and wish you a great rest of the day. Thank you.
Thank y'all.